All right, this is Blood Gas of the Week, case number 4. Make sure you've got your answers all ready for the scenario. Here we go. A 7-month-old male intact domestic short-haired cat is presented in severe respiratory distress. About an hour before presentation, the owners heard him cry out from another room and found he'd been chewing on an electrical cord. He initially seemed fine, but a short time later he seemed to be breathing a little bit faster than usual, and he's rapidly progressed to severe difficulty during the 15-minute drive to the emergency hospital. At presentation, the cat prefers to sit in sternal recumbency with his head and neck outstretched. He has coarse crackles in all lung fields, and he gets really frantic with any restraint. He's rapidly becoming exhausted in front of you, so you pop him into an oxygen cage and just watch him for a few minutes. After a few minutes of oxygen supplementation in a quiet area, you're able to minimally restrain him and obtain some vitals and initial labs. So, here's what we've got. And the first step, as always, is to see if you have an arterial or a venous sample. This one's venous, so we can go straight on to our acid-base analysis. The first step is to evaluate the pH. This cat's pH is 7.31, pretty low, so this is an acidemia. An acidemia can be caused by either a high CO2 or a low bicarbonate. Our patient's bicarbonate is high, so that's not the cause. His CO2 is 52. This is a respiratory acidosis. We would expect to see the bicarbonate rise in response to the acidosis, and that's what's happening. If you prefer tic-tac-toe, we see that the pH is low, which is acidemia. The PCO2 is high, which is an acidosis, and the bicarbonate is also high, which is metabolic alkalosis. So we look to see which process lines up with the pH. In this case, it's the CO2, so the primary process is a respiratory acidosis. The bicarb is over in the opposite column, so this is probably compensation. So, our acid-base diagnosis is a compensated respiratory acidosis. Since some of our really sick patients can have more than one problem that can cause changes in the blood gas, we can use math formulas to determine if the changes that look like compensation really are compensation, or if we've got to go looking for other problems. When the primary problem is an acute respiratory acidosis, the formula says that for every 1 point increase in the PCO2, the bicarb should increase by 0.15 points. So let's take a look at our patient. Step 1 is to see how much the CO2 has changed from normal. A normal CO2 is about 40, so we're going to subtract 40 from our patient's measured CO2 of 52. That gives us a change of about 12 points. So, for every 1 point change in the CO2, the bicarb should change by 0.15 points. We multiply 12 times 0.15, and we'll round the answer to the nearest whole number, which is 2. So we think the bicarb should go up by about 2 points in response to the abnormal CO2. Normal bicarbonate is about 20, so we add 2 to 20 and get 22. This means we would expect the bicarb to be about 22 if the change in the bicarb is just compensation for the respiratory acidosis. But we know that there's actually a range of normal for CO2 and bicarbonate in our patients. Not everybody's normal bicarb is 20, and not everybody's normal CO2 is exactly 40, so we need to use a range. And as a general rule of thumb, we're going to use a range of plus or minus 2 when we talk about metabolic compensation. So our calculated value is 22. 22 minus 2 is 20. 22 plus 2 is 24. So if the patient's bicarb falls into this range of 20 to 24, we say the change in bicarb is probably all due to compensation. Our patient's bicarb is 23, falls nicely into our range, so his change in bicarb is probably compensation for his acute respiratory acidosis. So, our final diagnosis today is a compensated respiratory acidosis. Thanks for watching. We'll see you again next week. Until then, keep the rubber on the road and the blood inside.